Good evening, everyone. Hope I am audible and clear.
Yes, Sripriya.
Thank you, ma'am. Thank you for confirming. So, welcome you all once again to the 13th session of our foundation course in palliative medicine. Today, we'll be discussing about the respiratory symptoms, but one of the most common symptoms, but yet much less thought about symptoms. And we have the eminent faculty, Dr. Rutula Sonawane, joining us back to walk us through the session. So for formally inviting her back and just introducing her and then further session facilitation, I hand over to our esteemed facilitator, Dr. Ratha Venkatesh. Ma'am, it is over to you.
Thank you, Sripriya. Good evening to one and all. See, we are nearly halfway through our sessions, now we are in the stage of going through various symptoms which are to be dealt with in detail. Of the lot, respiratory symptoms like pain, respiratory symptoms are one of the most common. Roughly, they say like pain and respiratory symptoms together cover 80% of the problems which will be faced by any palliative care patient. So, being an important one, we're going to go through that in detail today. Okay, and for that, we have Dr. Rutula Sonawane, who you're all aware of, who took us through one of the sessions ahead. She is an assistant professor in palliative medicine in the Department of Critical Care Medicine 2 at Bharati Hospital, Pune. She has completed her master's in palliative medicine from Tata Memorial Hospital, Mumbai, and currently works in the Bharati Hospital at Pune. Her main interests are in research, elements of palliative medicine, and especially in non-oncology, which she took us through in the palliative care armamentarium. And she also has keen interest in the pediatric population. So, and the main next thing is that, as we have been always telling, we want this palliative care to reach the nook and corners of India. So, for that, what are we trying to do? So, that is also one of her main interests. With that, I hand over to you, Rutula, to take us through the session today.
Thank you so much, ma'am. I'll just start presenting my slides. Can you all see it?
Yes, Rutula, it's visible now.
Yeah.
Visible and you're audible too. Go ahead.
Great. So we'll discuss a bit about respiratory symptoms. They basically consist of all these when you normally look at it. From a palliative point of view, it is mainly the shortness of breath or breathlessness and cough that is important. And as ma'am said, along with pain, it makes up around 80-85% of this problems in palliative care population. So I'll be covering shortness of breath and cough in detail, but there are a few others like airway secretions, hemoptysis also, but those are, I mean, they are not just respiratory, right? It can occur because of other things also. So I'll just brush up upon them at the end, like we'll discuss them at the end of the session. Coming to breathlessness. So we'll discuss it under these topics. Basically, the definition of breathlessness, its prevalence, impact, few models, and management. So according to the American Thoracic Society, breathlessness or dyspnea is an subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity, right? So, and as we all know, it's one of the most common symptoms that is reported in terminal cancer patients, especially during the last 6 months of their life. Now, coming to the prevalence of dyspnea, in cancer, overall, it is around 10 to 70%. In lung cancer, around 60 to 95% of the patients would have dyspnea. Advanced heart disease have around 60 to 88%. COPD has around 90 to 95%. Even CKD has around 60% of patients may have it, and then it reduces as you go down. Now coming to the mechanism, as you can see, the brainstem usually has the chemoreceptor or air hunger is felt through there. So all the sensations from the upper airway, the chest wall, and um, uh, the bronchus and everything would go to the chemoreceptors. From there would transmit the signals to the brainstem, which would then take it to the sensory cortex. So that is the afferents, and the efferents would be sent in by the motor cortex downwards, which will basically try to catch up or relieve the air hunger that the person is feeling by using ventilatory muscles and the upper airway also, like, so clearing out. So cough can be induced, and all the other compensatory mechanisms would be activated. So it is a major detriment for quality of life, right? Because the patient is unable to even carry out his activities of daily living. So there is, as a consequence, it will have social isolation. Then sometimes the patient might feel, kind of fed up with all the things that are happening, and will reduce the will to live as well. And is the second most commonest reason why we initiate palliative sedation. So as I had mentioned this before as well, so breathlessness should be looked at from three aspects. It's the breathing pattern, the thinking pattern, and the functioning pattern. So together, this is the breathing, thinking, functioning pattern for breathlessness. So breathing, basically, it is ineffective breathing, and there's also an increased work for breathing. So all the use of accessory muscles, and there is hyperinflation of the lung, and respiratory rate is also increased. So all these leads to breathlessness. Now coming to thinking patterns, there would be anxiety, distress, panic feelings, misconceptions because of previous episodes of such breathlessness, and increased perception of those sensation, past experiences and memories kind of accentuate the whole perception of the sensations that they have, and they might even have a feeling that this breathlessness would lead to their death. So this kind of increases the anxiety, which again in effect increases the sense of breathlessness. And because there's already in breathlessness and effortful breathing, what it leads to is reduced activity, self-isolation, and being dependent on others for their day-to-day work. So this in effect leads to deconditioning of all the muscles of the limbs, the chest wall, and the accessory muscles, which further lead to reduced activity and increased dependency, which again leads to breathlessness. So all these factors come into play. So when we are thinking of managing breathlessness, we need to address all these points. So we should help for the sensation of breathing, or more increased breathing. Handheld pan or breathing techniques can be taught so that it reduces the work of breathing, and it leads to effective breathing patterns. For thinking patterns, we can give them relaxation methods. Counseling sessions can be done to address few specific points which lead to increased distress and anxiety management along with that, which help in reducing the anxiety and in effect the increased work of breathing. And physical activity, exercises, physiotherapy, chest physiotherapy, any aids while doing the daily activities can also be encouraged, so as to improve the functionality of the patient and thus help reduce breathlessness. So those are the factors that we need to keep in our mind, so that we manage the breathlessness in the best way that we can. While coming to the assessment, we need to look at the quality of breathlessness, the intensity of breathlessness, what impact it has on the person, and the distress that it is causing. Now, for qualities of breathlessness, usually a few things would kind of be pathognomic of certain pathophysiology, like Chest tightness or constriction is generally with bronchoconstriction or interstitial edema, especially in asthma patients. Increased work of breathing can be associated with airway obstruction or neuromuscular diseases, or there is decreased chest wall or pulmonary compliance. It can be seen in COPD, asthma as well, and pulmonary fibrosis. Air hunger or increased urge to breathe is increased respiratory drive, basically. So pulmonary edema, your cardiac failures, and acute exacerbation of either COPD or asthma. Rapid shallow breathing is usually seen in interstitial fibrosis. The smothering or suffocating sensations can be seen in pulmonary edema, and heavy labor breathing can be because of deconditioning of the muscles as well. Now we'll take it up as cases. So this would be the common pattern. Like, so this is the main case, and we'll take up different scenarios for different causes of breathlessness, and let's see how it comes up. And please, I would like everyone to be a bit more interactive, either in the chat box, or you can just unmute and then answer, and we'll go ahead with it. So it's a case of an 85-year-old female who is a diagnosed case of CA endometrium. She is morbidly obese and a known hypertensive and diabetic. Now she's for best supportive care. Initially, she's received 2 lines of chemotherapy and radiation as well, but does not seem to have helped her a lot. Now she's currently presenting with would you like to know anything more or any history or investigations? Okay, so scenario 1, she has been an asthmatic and has not been taking regular medications. So this is what her X-ray looks like at the moment. Can you see the X-ray? Just give me a minute. Yeah. So this is what her X-ray
Yes,
looks
Rutula, we can
Yeah.
see.
Yeah. So how would you manage this patient in case she has been an asthmatic and not taking her inhalers?
Someone has asked whether she has dyspnea, history of dyspnea.
Yes, she is breathlessness. She's presenting to the she's presenting to your emergency department with breathlessness.
Messages on the chat, Rutula, like
Yeah.
suggestions what they've given. You could, if
Yes.
you want me to read, let me know.
Yeah. So yes, so you would advise her to start inhalers, but current would be, as Swati is absolutely correctly said, is that you'll give her nebulizations first, just to get over the acute exacerbation that she's having. Rule out if there has been an infection, because it's a sudden onset, and if she was not requiring inhalers previously, so it might be the infection which is causing her to have the acute episode of asthmatic exacerbation, and we might need to start her on antibiotics as well and bronchodilators. So you would give nebulization with steroid and bronchodilators. Usually we give Duolin, which is in combination of ipratropium and salbutamol, and Budecort is given as nebulization to go with. Injection hydrocort can also be given, and antibiotics according, you can give a empiric one, and then if any investigations are done, then you might change it according to the sensitivity profile as well. Now, this is the second one. Again, so it's a 85-year-old female with endometrial carcinoma for best supportive care, morbidly obese, hypertensive, diabetic, now presenting with lung metastasis, hemoptysis, and cough. Any difference in the way we manage the patient? And she is presenting to you with breathlessness. What would you give in this case? Chemotherapy, she's for best supportive care. She won't be able to tolerate any, further chemotherapy. So she's not a candidate for any disease-directed therapy. Acute attack management will be the same. Yes, maybe. Yes, correct. So nebulizations can be given. For lung meds, it's, as you can see, it's like, cannonball appearance. I'm not sure if you can give radiation therapy to all of them, because it will cause, it will, cause interstitial damage as well. So oxygen therapy, yes, if she's requiring, yes. Anything else? Yeah, you might have to put her on like inhalers if you feel that the broncho constriction element is more. You might have to, you might start her on inhalers. Yes. Anything else? Oral steroids? I cannot read your messages otherwise. Okay, I'll just share. Yeah. Okay. Can you see the CT scan? Because I think it's blocking, the chat is blocking. Just give me a minute. Okay. Cough suppressant. Okay.
Can see reply. The both are the CT is seen well.
Okay. Oral steroid would be a good option here, because all the lesions would have some element of edema surrounding it. So steroid should help in that way. Plus it has some anti-tumor property as well. So it, I mean, not completely, but it has some action to reduce the tumor size. I mean, it's not very obvious, but it can help in that sense as well. Another thing, cough suppressant, any specific cough suppressant you were thinking about? Codeine, okay. Anything else? Morphine can also be used, right? Because codeine gets converted to morphine and then starts its action. So you might as well just start off with morphine, lower the dose also. I mean, codeine you would have to give around 40 mg if I'm not mistaken. So we can start off with a lower dose as well. So morphine would be preferable. Opioids, usually morphine and codeine seem to work better for cough suppressant and for breathlessness. Fentanyl, so technically it should help with cough and breathlessness, but sometimes there are certain episodes of increased breathlessness with fentanyl patches. So we need to be very careful when prescribing those for breathlessness. So yes, opioids, specifically codeine or morphine, whichever is available, easily available in your area or institute. Coming to the next scenario, just give me a minute. The patient, as you can see, is presenting with effusion, and the patient had history of dry cough, which was increasing when the patient was lying on the left lateral position, and there was heaviness as well. So this is the X-ray. What would be your line of management? Thoracocentesis, okay. Aspiration, tapping. Can anyone tell me how much fluid would you remove in one go of tapping? Like ICD insertion is fine, but if you are doing pleural tapping, how much? Oh, you go up to 1.5 liters, because I have had episodes of patient developing edema after removing one liter. So I've always been very skeptical. So usually we, even in Tata, we would remove around maximum of a liter, but less than that usually. So around 800 to 900 cc would be removed. But okay, 1.5 is also doable. Okay. And what would you prefer, ICD or pigtail? Is there any difference? Yeah. Pigtail is possible. So the only problem with pigtail in malignant effusions would be that there is, if it is an hemorrhagic pleural effusion, it might just get blocked. So you might have to change the pigtails a couple of times before it's drained completely. And if we are planning to do an pleurodesis post pleural effusion drainage, then we have to put an ICD again to do the procedure. So sometimes, because it's a larger bore tube, the ICD tube, it's better because the chances of it getting blocked repeatedly is less. So, but it again depends on patient to patient also, and institute to institute also. So whichever is feasible would be it. If it's not, it's not. It's like a clear fluid, then pigtail is ideal because it's a small one and it is comparatively less painful. But if it's hemorrhagic, an ICD would be preferable. Coming on to other causes can be cardiac, like acute myocardial infarct, arrhythmias. You have your pericarditis, pericardial effusion, pulmonary edema, left ventricular failure as well. Pulmonary causes, as we already saw, it can be exacerbation of asthma or COPD, can be pneumonia, pneumothorax, pulmonary embolism, large airway obstructions due because of anaphylaxis, foreign body, or carcinomas, like obstructing the main bronchus or the bronchi of the lungs. Altitude illness, anxiety, hyperventilation, diabetic ketoacidosis, and thoracotoxicity are other causes. Coming down to the management. So basically what we are looking at is managing to reduce the symptoms, right? So how to minimize the production of these symptoms? It can be endurance building or endurance training, that is exercise training. There can be certain breathing techniques such as post-sleep breathing or diaphragmatic breathing. Supplemental oxygen whenever required. And always remember, oxygen is also a medicine. So use it very stringently, and when necessary, do not give it just like that. Nutrition also plays an important role. We can diminish the perception of breathlessness. So handheld fan, pharmacotherapies like opioids or benzodiazepines, distraction methods like cognitive behavioral therapy, music therapy, or focused imagery techniques. Then stimulation of the afferent nerves, that is the chest wall vibration. I'm not sure if it's available everywhere. I mean, I have personally not experienced this, but this is very effective. And if it's available, it can be tried for patients with severe breathlessness. Then reduce impact of the symptoms. So there should be lifestyle modifications to conserve the energy and do the activities that need to be done. So energy management, posturing, and certain modification to help carry out the daily activities and maintain the functionality of the patients, and also modify the impact the breathlessness has on the patient. So if there are episodes of exacerbation and you know what the cause might be, so you plan for such episodes of exacerbation. Then if there is any underlying anxiety or depressive disorder, then manage that as well. And always look out for what the patient's interpretation of his or her symptom is, and address those issues as well. I've not mentioned it here, but other techniques like acupuncture and vibration, chest wall vibration is also here, but certain other non-pharmacological techniques are also effective. So if you know of people who are providing such therapies, then you can look out for them and ask if it's feasible for them to give it to these patients. So coming to the mechanisms by which opioid reduce the breathlessness, and according to the American College of Chest Physicians, it is a grade 1A recommendation. So basically, as an analgesic, though, if the pain is inducing the breathlessness, it helps with that. It has certain anti-anxiolytic effect as well. It blunts the afferent transmissions from the mechanoreceptors in the chest wall to the central nervous system. It also has a cortical sedative property. It alters the neurotransmission within the medullary respiratory centers, which in effect blunts the medullary sensitivity and response to hypercarbia and hypoxia. It also decreases the metabolic rate and ventilatory requirement. And because of the vasodilatory effect, it improves the cardiac functions. So it helps reduce breathlessness via that mechanism as well. So in palliative care setting, usually while managing breathlessness, oxygen is given because it improves the saturation, and because of the air that is coming directly onto the face, it has certain placebo effect in reducing the sensations as well. So basically, it's medical symbolism also, because usually when patient comes to any hospital and is breathless, the first thing they'll do is put on the oxygen, then do everything else. So as our medical symbolism as well. And it also causes decrease in breathlessness by central inhibition. Benzodiazepines as an anti-anxiolytic, usually short actings are preferable, such as midazolam, which is most commonly used in our setting as well. Phenothiazines, off-label, the mechanism is not very clear, but it shows a certain effect according to literature, but I'm not sure if we use it as commonly. We usually prefer just benzodiazepines and combination of bronchodilators, steroids, and opioids. Bronchodilators when there is airway obstruction or airway constriction. So usually beta-2 agonists are preferred. Diuretics, now certain literature states that in certain cases, nebulization with furosemide, especially in the presence of pulmonary congestion, has reduced the breathlessness. Now, it's not very effective in all the patients. We have tried it in our patient population as well in data, but not all the patients benefited from it as much as we hoped that it would. Certain patients did, certain patients did not, and we could not pinpoint as to which would be where it could be more beneficial, but you can try it and figure out a way to give that as another mode of management. Steroids, if there are any compressive lesions, it helps reduce the edema surrounding it, especially helpful in lymphangitis, already used as in COPD or bronchial asthma exacerbation, either methylprednisolone or dexamethasone, whichever is used. Anticholinergic, again, as bronchodilators and to reduce the airway secretions as well. So hyoscines, you have the glycopyrrolate and atropine as well. Non-invasive ventilation can be used, your high flow nasal cannula or NIV settings. It can help reduce the respiratory acidosis, and that is present in COPD or hypoxemia in cardiac failures as well. Then coming to management of dyspnea and severe COPD. So according to GOLD, it is first you start off, you optimize the bronchodilators with plus minus supplemental oxygen whenever required. Then if it is persistent or is increasing, then you go on, you add non-pharmacological measures to it as well. And then palliative pharmacological measures such as opioids, benzodiazepines, and can be added. And if it is working well enough, if it's not, if it's still persistent, then we might have to go for sedation as well. Then coming on to cough, again, we'll cover what exactly is the cough, what is cough, mechanism, causes, and its management. So it's basically sudden expulsion of air through the larger airways to clear out the irritants, fluids, foreign particles, or microbes in the airway. Basically, mechanism is in 3 phases. So one is inhalation, then you forced exhale against a closed glottis, and then there is violent release of the air from the lungs following the opening of the glottis, which produces the distinct cough sound. Coming to the mechanism, as you can see, there is obstruction, then the air is like inhaled, then forced expulsion against the glottis, and then it opens and it produces cough through the vagus and the superior laryngeal nerves. This is just a bit in more detail. So efferent pathway basically coordinates the muscle response in the intercostal regions, intercostals and the diaphragm muscles. And so basically what happens is vagus nerve transmits to the NTS and cough center, which leads to diaphragm via the phrenic nerves in the spinal motor nerves and produces cough. Causes, acute or subacute, most likely because of a respiratory infection like common cold, which can be viral, bronchitis, pneumonia, pertussis, or tuberculosis. Chronic cough is more than 90% is due to your postnasal drip or asthma, can be bronchitis, or sometimes even gastroesophageal reflux disease can also. In pediatrics is usually bacterial bronchitis. Smoking, air pollution causes a lot of cough, choking sensations as well, bronchiectasis, cystic fibrosis, ILDs, cancer, and sarcoidosis are a few causes of chronic cough. It can be psychogenic, neurogenic, it can be related to heart failure, medication induced as well, especially ACE inhibitors. So coming to the management, simple home remedies can be used, such as drinking a lot of fluids, cough drops, or hard candies can sometimes just soothe out the sore throat. Honey is helpful, especially mixed with ginger or clove. It kind of soothes out the posterior pharyngeal wall, which helps reduce the cough sensation. Breathing in moist air helps with the cough, and avoiding irritants like tobacco can also go a long way in managing. Coming to the pharmacological management, opioids, which basically are central cough suppressants, so morphine and codeine. Generally, you start off with around, if it's opioid naive, I would still start off with 2.5 mg Q8 hourly and then titrate it according to the need of the patient. But if it's not opioid naive, then calculate it according to how much the patient would need. Non-opioid cough suppressants would be dextromethorphan, which is again the most commonly used in our setting, and mucolytics to thin out the secretion so that it is better coughed out or expectorated out of the system. So nebulized saline or guaifenesin, or even an acetylcysteine, that also helps a lot. It can be given as nebulized in the nebulized form as well. Then bronchodilators, again, salbutamol, which will help reduce the or rather help in the secretions that are accumulated and helps remove it effectively, and also help with the breathlessness. Ipratropium will reduce the inflammation. Steroids also the same action. Anticholinergics will reduce the secretions that are present especially so glycopyrrolate can be given as subcute injections and titrated up according to the needs. Usually you can start off with twice a day dosing and then increase accordingly. Sometimes nebulized lidocaine can also be used, but again, it depends on whether it will help the patient or not. Sometimes even you get those dextromethorphan lozenges. That also sometimes helps a lot with chronic irritant cough. If not the cough with expectorations, but irritant cough with no or minute amount of expectoration. The lozenges also help a lot. Persistent post-infection cough, anti-inflammatory agents, bronchodilators, and cough suppressant. Combination of this helps a lot in managing persistent cough. I think that is the end of my presentation. So I just would like to still cover hemoptysis. So especially in oncology patients or even sometimes in ILD patients, because there is persistent cough and usually it is irritant. Sometimes hemoptysis might be present and usually it is small vessel bleeding. So any thoughts on what would be your line of management if the patient presents with hemoptysis? Let's say it's a case of the same patient, CA endometrium with lung metastasis like frank cannonball appearance, and she presents to you with hemoptysis as well. Okay, she did have hemoptysis there as well, but she presents to you with hemoptysis and breathlessness. How would you manage that patient? Morphine for breathlessness, excellent. Anything else? For the hemoptysis, I'm talking about the hemoptysis part of it. Steroids will not help with the bleeding. Rule out infection, okay. Try Tranexa. Okay. Usually a combination of Tranexa and ethamsulate helps a lot. Because supposing it's a tumor bleed, usually tumor bleeds are capillary bleeds usually. So ethamsulate is better for capillary bleeds than Tranexa. And I'm not saying that Tranexa will not work at all. Tranexa's mechanism of action is via the platelet aggregation. Ethamsulate works on the capillaries and helps it to constriction, basically vessel constriction. So two different mechanism of actions given in combination would have an additive effect. So combination of both of them helps a lot. And artery embolization or ligation is the last resort for any massive bleed. Okay, and so I think that's about it. Any other questions that you might have?
Thank you, Rutula. We will just wait for them for the questions. Yeah, like see, as we started off telling the importance of the respiratory symptoms, and it is a big element, and that is important in element of symptom management. Okay, if that is why we have been telling that why this like pain and cough or breathlessness, both of them, something puts the patient off and their normalcy is affected. So that is why these come as on top of the list. Just a very important thing, as we were telling the other day also, this breathing, thinking, functioning model. That is the take home, I would say. And then especially that one slide per se has the problem and the answer to it, if you all have a look at it. So, and it is very, very well said that it creates a vicious circle. So what happens is one links to the other. For example, we have all gone through it. So breathlessness, then apprehension. So they start thinking, oh, I will become. See, unfortunately, not thinking in the right way because they have not had the experience of having had the relief of symptom. So it goes on to that. And then it goes on to the functioning model. So what we say, generally, it's better to break that vicious circle. You can break it at all ends of it, all three levels. So that is what is given in that small blue boxes or the small blue circles. So the white circles are the problems, like breathing, thinking, and functioning. And in between, if you see, those blue small circles have the result or solution for this. So that is something, see, if you all have a look at it, and that is something which you take it from there, how it is, that's the pathophysiology or whatever it is. And for that also, each one, how you manage. You make the breathing efficient. So just teaching them either the mindfulness or any technique, mindfulness, CBT, they're all techniques which are taught and which is very simple and everyone knows. It's just the anxiety and fear which avoids it. So by doing that, the same breathing becomes efficient and effective breathing. So that is the important thing. So that one slide is so self-explanatory because it's got the problem and the solution in it. So, and then finally what is done is making their own breathing efficient and effective by the techniques. So their symptom is relieved. And once the symptom is relieved, they start to do their function important. See, there are some simple things called as chair exercises, sit stand exercises. So which are all taught for these type of patients. Okay, so not that they cannot do anything. And another important thing is that when patients are in that stage, when they come and see you, they are unable to do very intense exercise. So whereas if you teach these to them, I remember in one of the conferences or something, in many clinics and things, they just tell them when you're waiting in the waiting to see a doctor or something, even that time they can do 4 times if they feel like. So that will also allay their anxiety. So all these can be taught to them and told how. So because you have to teach them, it's not something totally impossible or something. So if you tell them and then they do it, they gain more confidence. So that is something very important, and morphine is used very well for this. It relieves the symptom, and literally in 2 to 3 days they will see the difference. I've seen a lot of either cancer patients or mostly when it works very well in terminally ill patients, because that's when they are struggling, and when they get relief, and everyday quality of life matters, and they'll be able to talk. See, what we normally say, breathless patient cannot complete full sentences. That is a very important thing which is said. So which, when they're able to do that, gives them so much of relief and comfort. So those are things to be taken from this, because breathlessness and breathlessness management, morphine in breathlessness management has took us a very good long way in helping the patients. And one important thing, the dose what is used is very important. We don't use the dose what we use for pain management. Okay, so that has to be kept in mind. So I'm just checking if there's anything in the chat box. A glycopyrrolate. Glyco can be used as IV and inhalation or only as subcutaneous, madam. Is that glycopyrrolate someone is meaning?
It can be used as IV formulation as well. It's just that it causes a lot of dry mouth. Even sometimes will lead to like extreme dry mouth. So sometimes they're like, secretions nahi hai, but my mouth is so dry that I cannot do anything. So we'll just have to titrate the dose well. That's all. You can give it as injectable as well. Inhalation, I'm not so sure, but you can give it as injectables, IV injectables also.
That's also, it was like, yes, we do use IV, but as always, no, you have to see the side effects, how comfortable the patient is going to be. That's the thing to be taken there. So anything else? Go ahead, Rutula.
So for excessive secretions, oral secretions, especially in oral cancer patients, glycopyrrolate gargles can be used. So one vial in a cup of water, and then just hold it in the mouth for a couple of like a minute or so, and then just spit it out. So it helps dry the mouth, which is helpful there, not here, but it can be used as that as well.
Exactly. See, everything, no, you have an idea of everything, how they can be managed. You use it according to the situation or what is the need of the patient. So see, especially these vials using and all, no, so we are trying to use whatever is available, and that with that you make good. So that's what, see, because if that's not available, see, that is how we will be teaching more also. We teach a lot of home remedies in these, because not that everyone needs to have or something which has to be ready made bought from the shop. You can do so. That's another important element of this course as such. By at the end of it, all of you will be able to recognize that. That is how efficient you can be. You can't say, oh, I don't have, so you have something. So we try to bring in those type of ideas which everyone is aware, just to use it appropriately at the right point of time. So is there anything else more in the chat box, Rutula, or shall we go ahead with the case presentation and come back?
Yeah, I think we can go ahead.
Sripriya, I will hand over it to you to go ahead with the case presentation, and then we can come back. So that can have the discussion for both.
Hello. Ma'am, am I audible?
Yes, yes, you are audible, dear. Go ahead.
Hello. Actually, I'm talking while I'm going in car, so a little bit of disturbance will be there. Kindly pardon me. The patient is 58-year-old male. He's diagnosed with type 2 respiratory failure, COPD, acute exacerbation on mechanical ventilation. Next slide, please. Presenting complaint is breathlessness, cough with expectoration, type 2 respiratory failure. Next slide. He's had breathlessness for the past 8 years on daily medication, aggravated with when exposed to cold and dust, and while walking uphill. Patient has to stop for breath, and the breathlessness is relieved by inhalers. He had 3 episodes of hospital admission in the last 1 year. Last exacerbation was 2 months back, and for which he was admitted in the hospital. Patient has cough, which is productive, with mucoid scanty, not blood stained, no history of chest tightness or chest pain. Past history, old pulmonary tuberculosis with fibrosis of the left lung. Next slide, please. Examination findings. He's on mechanical ventilation, on pressure control ventilation, day 25. On pressure control support of 15, PEEP of 6, respiratory rate 14, FiO2 of 40%. With this setting, he's getting a tidal volume around 300 to 350 ml. He's conscious and obeying commands. The pulse rate is between 90 minutes per minute, BP of 140/88, SpO2 of 95 with 40% FiO2. Chest X-ray, right, chest on examination, air entry is decreased on left, middle and lower zone. Air entry is present the right side of the lung and the left upper lobe. S1 and S2 normal. Other systems are within normal limits. This X-ray is which is there is a pre-intubation X-ray. Treatment. He's receiving nebulization, antibiotics, Riles tube feeds, and symptomatic management. Next slide, please. Psychological aspect. He was working as a painter, but not able to go for work due to the frequent respiratory distress. He's married, having 3 girl children, of which 2 children are married. Wife was working as a domestic help and supporting the family. The younger daughter is working in a nearby company to support the family, meet both ends. Medication, nebulization with acetylene nebulization TDS, budesonide nebulization TDS, ipratropium bromide nebulization TDS, and he's on a higher antibiotic, pipped as 4.5 gram 12th early because of the pneumonia he's developed recently, and injection flagyl 500 milligram TDS. He's on Ryle's tubes feeds. The main concern here is patient has been on persistent hypercarbia while trying to wean him off from the ventilator and support him with non-invasive ventilation. The carbon dioxide keeps building up and the PCO2 goes above 100 and he goes for narcosis. So we had difficulty in weaning him off the ventilator. So plan for tracheostomy on day 10 as weaning was difficult. Patient attenders didn't give consent for tracheostomy as he has been repeatedly getting admissions on NAV and on AT tube. He was coming out of the ventilator. So this time also they had still hope that he will come off ventilator. Had to change the endotracheal tube in this 25 days. 4 times we had to change. Of this, twice it was tube blockage and near arrest, cardiac arrest. Summary, 58-year-old male with type 2 respiratory failure, COPD with exacerbation, difficult to wean, no tracheostomy consent. Next slide, please. Discussion points, COPD with frequent hospital admission. Can we defer invasive ventilation? Can we take a decision of surgical airway to wean the patient? Should we resuscitate the patient next time he has a cardiac arrest due to endotracheal tube blockage? It's a very difficult situation for us. Thank you.
Thank you, Dr. Amadevi. Like the case per se and how it has presented, it is really a very good case to as a learning model one. So I think I will leave it for everyone to participate in the discussion and move forward. And when it comes to that stage, we will go on to each one. So I will reiterate all the important points here, and then we can come out of this screen, Sri Priya. The main things what we're looking here is COPD. How good or how bad is his COPD, and his frequent hospital admissions. We will go through them. He has had 3 in the last 1 year. And can we defer invasive ventilation? That's the question. And then can we take decisions of surgical airway to wean the patient? So first, once you go into invasive ventilation, when you make the decision of coming out of that, how and what are the modes of weaning? And then should we resuscitate the patient next time he has a cardiac arrest due to endotracheal tube block? Okay, so these are the things we're going to have. If we come out of this thing, Sri Priya, then we can have the discussion with everyone participating.
Yes, ma'am.
Thank you. Rutula, I think you are also happy with the decision, or what do you want to do?
So it's an excellent case, and we see a lot of it in the ICUs. So it's like a very common thing for me.
That is why I thought this will be a one with, because we should have someone which everyone, all of you will face.
It's common for us also. That's why I presented, because it's very difficult to handle such situation.
No, like, see, we will give you, like, see, this is where you're going to get guidelines. Okay. So what we generally say is, see, and I'm not going to give anything from what you have presented itself, we are going to get. Okay. Only thing, as I said, the guidelines which will help all of us to get to track, and so that it's a medical decision. It is not one person's decision at all. Okay. This is what we have to help explain to the family also. It's not, because every time it is the feeling of guilt and things which is there. So that is where the medical decision comes in. Okay. So it's not that you are in making any personal emotional decision here at all. Okay. So, okay, let us see what is that everyone is coming up. See, first thing is that, does he need what invasive ventilation? What are the things which are going to help you to identify? Is the patient able to undergo consent process? How is he, Dr. Amadevi? What is the answer to that question?
Yes, he was conscious. He's conscious oriented, ma'am. He's conscious oriented.
So,
He's
okay,
able
so
to
he's able
sign
to
the
consent.
papers.
Okay.
Yeah.
Okay, so that question is answered. The first thing, no, like, does he need invasive ventilation? For that, what are the things that you will see? See, all of you have seen the 4 graphs, the disease trajectories. I think by now it should be by getting nearly like 3 out of 5 presentations, you'll be seeing that. So all of you have had that. So what do you think, which graph this patient will fit in? Exactly. So what, like, see, someone who has organ failure. So we have names for all those graphs. This is exactly a very typical patient who has a, who will fit into that organ failure. What is the significance of the organ failure graph? Can someone type in the chat? You have seen 4 graphs. Each one is unique to itself. So like that, what would you say? What is the uniqueness of this organ failure graph? Anyone can type or unmute, whatever each one feels comfortable. Please go ahead and tell me. Where do we start in organ failure graph? Where is the patient functionality or quality of life? Where is it? Top, bottom, middle, or where do we start itself? To start off, where it is. And next thing is that after each episode, how does it progress? For example, you start off with 50% capability. One episode, after the episode and recovery, where do they come? That is the importance of learning those graphs. Come on, team, something you all have to say. Okay, all the concerns and discussions. Let me read. All the concerns need discussion with the patient and consent, but patient needs to understand and take informed choices. Of course, patient's family members need to be in the discussion. Yes, that's what, explaining things clearly. This should start slowly prior itself, not at the third time when he's more, that is more sick or in a state where not the way he was as he came in at the first admission.
So, if I can just add something. So usually the problem lies in the fact that when the patient is diagnosed with, let's say, COPD in this case, the primary physician failed to explain to them the chronicity of the disease. They usually say कि ये दवाई लो ठीक हो जाएगा, or like the patient is going to get better, just take the medicines. They fail to explain it to them that this is like a damage to the organ and eventually would lead to deterioration with frequent admissions, and or like, they kind of fail to explain it to them that the organ function would decline over a period of time, and it's not going to be immediate, but not at the diagnosis, let's say not at the very first meeting, but once the patient starts having frequent admissions and requiring more inhalers, let's say, or requiring oxygen at home as well. So that is the time to initiate, we had managed the disease well for so long, and now it seems that it is going down the hill, and just explain to the patient and the relatives that the number of hospitals will increase, the number of chances of getting infections would increase. He would need to be put on ventilators. He would need some sort of aggressive management to just tide over the episode and all that. So if this conversation had taken place at the beginning or in the middle of it, instead of at the last end of it, it helps the patient to understand what is going on, take the decisions that they want to be taken. So somewhere it's the lack of communication that is, between the physicians and the patients that also lead to the stress of doing certain things or not doing certain things, like to be put on ventilators or not to be put on ventilators. And usually our referrals or the referrals for palliative department is given at the very end of it when they are thinking of stopping the ventilation or getting them off the ventilator to the non-invasive ones, and then just accept whatever is going to happen and all that. So that time the rapport between us and the patient is also not that great, or it's not there at all. So they might not even listen to us. They'll be like, do whatever you have to do, go aggressive, resuscitate them well, do everything. But that is not in the benefit of the patient. Like that might not be in the benefit of the patient. That might be causing more harm for the patient as well. So the system that we have in place is not very, it's not as good as it can be for such patients. So, but coming on to this particular patient, given the fact that there have been around 3 episodes of admissions before this, he's not maintaining it well on the ventilatory support as well, and having he had an episode of cardiac event as well, like cardiac arrest as well. It depends on what the relatives consent post that, but as a front, like what we do in Bharti is we take a mutual consensus of what is the condition of the patient amongst the physicians. Like, so if everyone agrees that this is not going anywhere, we do have a very honest upfront talk with the relatives and try to get them to understand the futility of the whole thing, and then help them make the decisions whether to continue the ventilatory support and aggressive management, to give a time limited trial, or to just withdraw all the support that is going on. So it depends on, at the end of it, if you're just putting everything to the last end of the whole trajectory, then it's the decision of the relatives usually, because the patient by that time is not able to tell you his wishes and preferences. But if it's like goes on through at least the middle part of the trajectory, then it's a decision of the patient and the family as a whole, and they have certain directives as to what to do and what not to do. So it becomes easier for us as well over the long period.
Exactly, Rutula. Thank you. That's what, see, coming to what, no, like what she's saying, when the patient starts to deteriorate, okay, the deterioration need not be only at the end of life, or like where the situation is not manageable, okay, from their quality of life, symptom management. With what, for example, with 2 medications he was managed, now he's needing 4 medications. 4 medications also, they are not working efficient. So there are so many clues. Frequency, so he, for example, number of medications increase. Now he was using 1 inhaler, he will use an extra one maybe once in 15 days. Now he's needing it every day. So those are situations when it is happening for you to pick up. And then coming to the question that I asked, when they start in that organ failure graph, what you see, even if they are having, every time they have 1 episode and recover, they don't come back to their 50% what they came in. So that is the important thing to see in that graph. Please, all of you, check that graph once again. For example, if that patient started off with 50, after first episode, it will be less than 50. So for example, I'm telling, if started off with 50, first episode, after he recovered, but he came back to 46. Next episode, 40. So you see that graph very, very clearly, please, all of you. So that is an indication. So to start off how they were, and then by the 3rd episode, where they are. So you put all these into perspective. These are what we tell as guidelines for you to have. And the usage of, so if you start telling them, so this is how to, not that first thing, no, as we always say, you're telling them this is the situation, and also telling them, don't think I'm telling that I'm not going to do anything for you. Whether it is the management in this part, like ventilation thing, or you want symptom management. So we are in a stage where the patient may need symptom management more than the curative management. So that is what always telling them and giving them the proper information that this also can be managed, not that we are not going to manage. We are always going to be with them. We will guide them in symptom management also. Okay. And that is where these things come handy. And next thing is that when the patient, like he or she will be able to tell you what is their preference, autonomy. See, you've all had session on ethics. So all those 4 elements, autonomy, you will do good, but no harm. All that you have to keep in mind. So it is our duty to explain. See, if the patient says that if I had known this is what is the condition, I might not have taken this decision. That stage should never come. As much as possible. See, there's no 100%. We can all try to do that so that they are made aware. So then that patient can make the decision and help the family and himself. Okay, so that is where, so if you tell like not at the first, see, you've had 3 admissions. First admission to Dr. Ramadevi, can you tell me what was the gap between, like, gap and the quality of, like, what was that he was able to do before his first admission and what was that he was able to do after his second admission?
Ma'am, as such, quality of life didn't improve, ma'am. He was on bronchodilators and he was at home. He was not going for any work.
Was he able
such.
to, no, what I meant is, what was he able to do his own
his own activities he was able to do, ma'am. Self-care he was able to do. Yes, ma'am. All the times he was able to do the self-care. That was not an issue. Only because this time he had a bronchopneumonia during the admission, and he was not. He was put on invasive ventilation. Otherwise, always he was on non-invasive ventilation, and he was going home after, say, 15 days of non-invasive ventilation. He was being weaned off. So this was the first time
so
he was
basically only on NIV and
yeah,
then
NIV.
he was not
Previously,
intubated,
always he was on
ventilated.
NIV. Yeah. This is the first time he had an intubation and ventilation. So that.
And one more thing, no, like all of you,
Yeah.
like as you say, COPD patients are the most difficult patients to wean off ventilator.
Yeah.
That is something known. So that is again which you have to tell them. See, it's like if it's COPD patients, sometimes you may have to take them to a stage of giving them like anesthetic gases. That stage also you can go. So being an intensivist, I'm able to take you through all those things, because see, that is the situation. Normal ventilation, what we use in theaters to manage patients is what you may, because they may not, because they've used so many inhalers and things, you may not be able to manage them with the general routine management. So much of bronchoconstriction may be there, and then CO2 increasing, narcosis is very common, and then you may have to accept some amount of hypercarbia. All these things are there. So managing a COPD patient, ventilation itself is not an easy thing. It is a challenge on its own. So you have to have all those things in mind with this patient. And then I think for your first question, no, all these you have to look into to make a decision whether that patient needs ventilation. And the second part, that going into like surgical airway, that was your second question. For that, what is the general, that is what, no, she had asked Rutula, like,
Yes, ma'am. This is the second question. Yeah.
So Rutula, you go ahead with that first.
Yes,
if you want to.
In general, if the patient is requiring a long-term ventilatory support, they usually shift from endotracheal tube to tracheostomy by the end of the week is maximum. By the end of the week maximum. So by the 5th or the 4th or the 5th day, yeah. So they would generally do an elective tracheostomy in any which case, just because he's requiring a long-term ventilatory support. And yeah, so because if the consensus among the family physicians is that they want to continue the ventilatory support, then they would have to go for ET insertion TT insertion. That's what I feel. But
yes, see, that is the general rule that, like, as you have said, Rutula, that is what is being practiced globally. that by day 4 to day 7, like if it is
Yeah.
if it is someone who will need, but also you have to keep in mind, it is just not doing a tracheostomy. Doing a tracheostomy is to help them to wean comfortably, because someone with an endotracheal tube to be on the ventilator, it is the most uncomfortable situation or most uncomfortable thing. So for ease of the patient is where we go in for tracheostomy. But you also have to have in mind, once the tracheostomy is inserted, then tracheostomy care has to be. So is that possible? How will that patient get? How long is the patient? How long the patient will need to be in the intensive care? And last but not the least, the financial situation also. So I'm not sure,
Yes,
Dr.
yes,
Madhavi,
ma'am.
what
Ma'am, here that is the main issue, ma'am. So one of the
that is
relatives
why.
who has informed them, actually the consent was taken by my senior resident, and then the END senior resident also came and explained first. At that time they agreed, but one of the relative came and told that once they do tracheostomy, they will discharge and send you home. Who will take care of him? That question was put to wife, and wife was not able to answer because she was not sure whether she'll be able to manage everything. But we as such,
Exactly.
we were not planning to shift him out or anything. They had that thing in their mind from somewhere. Actually, the pulmonologist was ready to keep him. Ours is a government hospital. So we were ready to keep him
Okay.
here till we wean him off that tracheostomy also. But from somewhere they got that thing. Maybe they might have seen some malignancy patient on tracheostomy or something. This patient was only having
Okay.
COPD. But that thing has brought all the problems, and they deferred tracheostomy. When the END surgeon came for tracheostomy, everything was planned. The day of tracheostomy, they told we are not willing because they
No.
had a feeling that we would discharge him. But nobody was able to convince them again.
If I
Whatever we
may
were
ask,
saying, they were not believing us.
what do you think was the prognosis of the patient?
Ma'am, actually, one lung is already destroyed with pulmonary tuberculosis. He has
Okay.
only one lung. Maybe we could have put him on tracheostomy because of this infection which was
Let's
there.
say 6-month
Yeah.
prognosis. What do you feel is the 6-month prognosis? Do
6
you
months
feel that
prognosis.
the patient would come out of this episode and be fairly independent, or do you feel that there is a chance of immediate
He would have been able to do his own activities. He will not be able to go for work or anything, but he would have been independent by himself, because earlier also we have done tracheostomy for COPD patients and weaned him and then send them on a home oxygen therapy after weaning them. That has been done previously, but this particular patient, we lost him after 45 days. That was a sad thing. He went for multi-organ failure and he didn't survive.
That's the thing,
So,
you know, because he
yeah.
already had an episode of cardiac arrest,
Yes,
which
ma'am.
itself
That was there.
says
Yeah.
that the
That is
prognosis was not very good. So,
yeah. That was because of tube blockage and hypoxia, ma'am. It was not because of his
but what
systemic illness
happened?
per se.
But what
Uh,
happens? The cardiac arrest itself has an effect on further exacerbating the whole
Yeah,
situation.
sure. That was there. That was there.
Yeah. So
Yeah, that
now
was
he
there.
has two
Yeah.
organ damages.
Yeah.
It's
Yeah.
the cardiac and the
Cardiac as well as respiratory.
yeah.
Yeah.
So weaning him off would have been more difficult after this.
Yes.
Like, you know, considering the fact that it is he has deteriorated drastically, I would say.
Yeah.
So
Yeah.
what I would have suggested was that explain the whole situation very well to the relatives, right? That it is not
Yeah.
good, the heart is also affected, blah blah blah. Give them all the bad facts, like upfront. Give them all the facts upfront, and tell them that we are trying to do everything that we can, and maybe we'll give a aggressive trial for 3 days, 72 hours, and let's see how the outcome is. So if the patient is not, because usually you would see the effect of the treatments in 72 hours. That is generally, that's how it works. So if it's not, the patient is not responding, and you feel that there's a chance that he would have to be maintained on ventilation for forever now, or might deteriorate early, then it's a good time, like after 72 hours, it's a good time to say, you know, maybe we should just wean off and accept whatever is happening, and, you know, not so as not to trouble the patient anymore further. That's how usually we do it in our institute as well. If we see that this is not going anywhere, we would give a trial of 72 hours and then take the decision of how to go further.
Okay, ma'am. Okay. Maybe the next time we have to start talking in that way.
Thank you.
That perspective.
Thank you, Rutula.
Thank
That
you.
is
We
yes,
have
doctor.
never
That
spoken
is
in this term actually. Actually, the main problem is when we see that wife and one more kid who is yet to be married and he's just 58. And again, we'll think, okay, we have to save him once more. Maybe that is that emotion. He has been coming and going from the ICU multiple times.
Yeah.
That is the main issue. Yeah.
Those are the obvious way I had.
Yeah.
I had a patient in the ICU. The relatives were not ready to wean him off. Like they were not ready to, and he'd become so cachectic. He was like just maybe 25, 30 kg, frail elderly. He was around 70 or something, 70, 75, frail elderly. And we were like, this is just troubling him. This is just causing him harm. He would cry because of the tracheostomy and everything. And we were like, he doesn't even want it. He just wants to, wants to be peaceful and all that. They're like, nahi, he's talking. The fact was that he was conscious oriented. He would respond in, mumbles and everything, or he would write down whatever he wants to say. So that was the reason why the relatives are also very reluctant as to take the decision of weaning him off the ventilator, because otherwise the rest of the organs were fine, right? They were working very well. So it becomes a tricky situation, but so that's why the importance of starting the discussion once the patient starts deteriorating instead of at the very end of it. And also just explain the prognosis very well. Usually the prognosis during such events is not like, I would not be surprised if he died in a month or two, like given the history that you have given me. So the prognosis was not good. So if you tell them that, considering the finances and everything, the families generally agree for withholding a further aggressive treatment or withdrawing the current treatment that is going on as well. It's just the communication that needs to be a bit more open.
Ma'am, actually the problem is here, nobody wants to take them off ventilator or anything. They just want whatever happens, let it happen here. We are ready to accept. That is the mindset that they're having.
So you can tell them that we won't be shifting the patient out of the ICU.
We have to
That
keep
can
him
be
on.
done, right? And usually once you wean him off, it'll be maximum of an hour or 2 hours that the patient then passes on.
That is it. That is it. So
you can keep him in the ICU. No, this doesn't matter. He'll be here. We'll make him as comfortable as we can. You can start off with sedation as well. So that's not an issue. Because ICU would be the place where morphine and fentanyl are easily available. Like outside in the ward, they'll be reluctant to give it as well. Especially in a government setup. That's what happens in our this thing as well. So, so that's fine. You can say that we'll be keeping him here. We're not shifting him anywhere. But I think it's time that we need to make this decision.
I would just reiterate that 72-hour trial, doctor. That is something which you have to do always. Even with this patient.
Next time on,
because
I'll
this
surely
is
try
something
that.
is practiced internationally. Okay, it's not one place. The 72-hour trial, you can go and search in all articles also. This is what is, and what they do is at the start of that 72-hour, how the patient was, and then this number of organ involved, everything is taken into perspective. So here we are doing always, we are doing good, not doing any harm. See, all those ethics points are kept in mind in these. So when you do like that, and if there is betterment at that 72-hour time, you see the 72-hour, it is completely. So that whether improved or deteriorated. And then here, no, it's an acute exacerbation of his COPD. It's an infective exacerbation from what you say. But at the same time, at that time, you even try an antibiotic trial. We include everything in that. So in that 72-hour period, numbers, functioning, the organ involvement, everything, the ICU chart is completely reviewed. From that start to that 72, every 24 hours it is reviewed. Okay, and then at that point you bring the family in also and
Yeah.
explain to them what is the situation. So as it is done in such a methodical way, so that is something. And here, no, like, see, they have to be taught, like, your important example of this tube lock can happen with a tracheostomy also. If there is no proper suctioning of the tracheostomy, no proper cleaning of the inner tube, everything is important. All these have to be taught to them. So everything, like any tube care, colostomy, tracheostomy, all these, no, tube care, ostomy care is very important. And even not that if we don't want to do, if they are happy to do and manage, okay, you will do everything in the intensive care, take care of them, and then make sure they are okay to manage everything. Or maybe you will even give a portable suction for them when they go home, something like that. I'm just giving you all these choices and options. So if you can do all that, then you can see. And then
Sure,
always
ma'am.
here you have to have in mind his cardiac arrest event is something
Yeah.
which has already affected his second organ. So that is what to have in mind. Like this only you have to
Yes, ma'am.
analyze each
Yeah.
one and take. And what the third question, what was your third concern, Doctor? Please, these two were, just bring that up. What was your third
Next
concern?
time you have a cardiac arrest, whether
When the
next
two,
time you
that
have a
one.
cardiac arrest, do we have to resuscitate that? Yeah.
So that one, like, go ahead,
Do we have
Rutula.
to? Yeah.
Again, it depends on the wishes of the relatives. If they want, they are like, go ahead with everything, then you, technically speaking, you would have to go ahead with the resuscitation as well. Now there is something called, if the patient or the relative is like कि जो होता है यहाँ पे होने viewpoint that the patient and the relatives have, like whatever happens, then there is something called as slow coding also. Like they do not go very aggressive with the resuscitation. They just kind of, if they know that the outcomes are not good, that it's only in that case, they go ahead with it. But if there is no return of circulation, then they won't repeat it again and again. So they kind of slow code it as well. But again, if it's done in the institute or the area, and if it goes according to the ethical committee of the institution, then I mean, it's not done everywhere, and people will be outraged if you just start doing it. So it has to be with the consensus of all the ICU physicians and everyone involved.
That is one big issue, ma'am. And if you don't do anything, then one person or the other person will be coming from that village, one Safai wala or the other. So they will say, see, nothing was done. Then it will go to another litigation. So usually we resuscitate whatever minimum possible, for even if the patient, we are sure that they will not come off because of this litigation issues which is likely to come. It's a small area, and people are coming from the nearby villages. Suddenly they will say nothing was done for your patient because they thought he's not going to come out. So we do whatever is possible. Maybe next time onwards, we'll have to think about this 72 hours trial as well as slow coding. Thank you, ma'am. That is a very good thing.
No, see, your medical team, you do you not have a, like, see, the patient, wherever, before the patient goes into the intensive care, that each particular patient will have one parent team or parent physician under whom that patient is. Being a government setup, you're telling, is that there or not? First question.
Yes, ma'am. It is the primary care physician is a pulmonologist, ma'am. Pulmonologist also tried explaining all these things. Actually, it was explained.
What I was
team only
trying
it was
to
explained, ma'am. Yeah.
No, what I was trying to say is, you have a pulmonologist, you can have a medical team, so that regarding this, not for this patient, as a hospital as such, you will have some form of, better to have some form of resus guidelines. So is that right or not, Rutula? Better to have a collective medical team. So they generally what we say is called as some research guideline being maintained by the medical. See, in that part, medical team or the parent team, intensive care, both have to be involved. It will not be one person. There's no I in team. No, so it's not. The team is made of few physicians.
Yes,
Either
ma'am.
physicians and the intensivist also involved, because physicians from the patient or primary care perspective, intensivists from the perspective of what are the stages or things that can happen in intensive care during and post. So that is why you should have a team involving both and have some research guidelines, which will help all of you. Because see, these type of things, these guidelines made will come handy in a long way. Go ahead, Rutula.
So you can even have like a committee sort of a thing where the treating physician, the primary treating physician, the ICU physician who is treating, and involve a non-treating physician also, because they will give a very non-personal judgment about the prognosis, that is the patient's prognosis. Because what happens is that if in such chronic patients, usually the treating physicians also become very involved with the patient. They have certain this family, this problem, that, they are kind of involved. So they look at it from a very personal view as well. So it's always good to have another non-treating physician as well, who is not actively involved in the treatment of the patient, and then take the decision very medically. I mean, not about anything else, just medically, just to look at the medical facts and see what is going on with the patient, and then take the decision of how to go further.
Just going to read some things in the chat, Ritula, so that we have covered. No, Dr. Meera has mentioned, with due respect to all doctors in the country, majority of doctors do not follow the consent process religiously. The three domains: supplying information, making them understand, and taking the permission. Very few when to do this second domain. Just saying patient or family do not agree means that consent process has been done properly.
Has not been done.
Has not been done. That's all. In most of such cases, trajectory or course of the disease is known. Sort of dialogue and advanced directive could. Advanced directive is something has to be, which I was also trying to come and say. That one can be made only if these things are informed to the patient ahead, and those decisions are made when the patient is in their best. Intensive care is not one-time activity. It should not be one-time activity. It should be dynamic process. See, that's what. See, intensive. Thank you, Dr. Meera. See, all those have to be kept in mind. That's why conveying the message, making sure that they understand. See, everything, like you all have to have the communication session in mind. No, it's not enough if I just tell it. Has the patient understood? Has the patient took it in completely? And is he able to say or explain what he has understood? That is important. Then without consent, we cannot do anything. And there you're not maintaining patient autonomy there if you are to go through that process. And then intensive care, as we have said, no, intensive care is something you all have to work hand in hand. And then the third team, what Rutula mentioned, you'll get an unbiased. And again, I'm telling, it's a medical decision. It is not one person decision. You are putting all these like organ failures, the patient response, you're seeing the parameters, everything you're doing. So that is what is, have all those queries or points of interest conveyed, confirmed, and understood, or anything else you want to add on, please do.
I would like to add.
Yes, ma'am.
Another thing. I'm sorry to interrupt. Just so such cases, supposing the patient with a chronic diseases, I'm not just talking about COPD, it can be CKD, it can be CCF, anyone, has an episode of, let's say, a long-term stay in the ICU for, let's say, 7 days or 10 days. At discharge, you can tell them that, there's a high chance that you might get readmitted. You might want this might happen. And what would you like in this case? Like, what would you like to be done in such situations? So you can just try to start the exploration at that time as well. So it's not necessary it has to be done by the primary treating physician. You can even initiate the conversation in the ICU and just explore what their wishes, preferences are. So, those might also kind of help reduce the ICU admissions or repeated hospital admissions. It kind of empowers the relatives to and the patient to take care of himself and so.
Can I ask a question to Dr.
Okay, ma'am.
Yes,
Yeah.
yes, please.
Dr. Rutula Brogan, I just wanted to know whether the Tata Memorial Hospital or your hospital presently have an ethics committee. You know, in such situation, I'm not talking about the research ethics committee. I'm talking about the ethics committee, clinical ethics committee. And they are the one who is going to play a very important role out here. So that include whatever you said, the primary physician, a theologist or religious person, a lay person, family members. How many of the hospitals have in India? Do you have any idea?
Not a lot of hospitals in India have an ethical committee. So I know that KEM Mumbai has a proper medical ethical committee. They have a department of medical ethics in their hospital. In our hospital, we don't have we have an research ethical committee. We do not have a clinical medical ethical committee. We do have a critical care review board, which consists of from the medical director, it goes down to the billing section as well, the social workers, and even the psychologists are also involved. So we, according to who the patients we are going to discuss, the ICU physician, ICU team is also there. Head of the ICU is also there. Then we have a medical representative from the medicine department. We have the primary treating physician, and we have a surgical team as well. So the decisions there are purely medical. Plus, we get an aspect from the social worker about the social status. We get a view from the billing section about the finances and everything. So everything is looked at very holistically and very impersonally. So, and if we see that the futility, like the treatment is futile, or there is no benefit of continuing the treatment, or maybe it requires a time limited trial, then that is how the decisions are made.
Okay, the futility is mainly decided by the doctor, but the patient party or patient has to have something in it also. It's not only because it's always controversial. Futility definition
Yes,
itself
but
is
the thing is that the medical futility should be defined by the doctor. It's a medical decision. Like you cannot get the patient's relatives' point of view into making it futile or non-futile. It's pure.
Not that decision I'm talking about. They might disagree with our decision. So
Yes,
that
yes,
committee I was talking about, I think it's high time that India think about it and have this committee.
Yes, I completely agree with you. But it's a long way ahead. I'm not sure if, I mean, people are not still, like the doctors are still not comfortable with discussing poor prognosis with the patient. They still want everything to be done for the patient. They still want.
That's exactly my point, why I said that one, because when we say we did informed consent, patient didn't agree, I'm a little uncomfortable with these words, because I feel that we don't do it very, very religiously in the way that it should be.
Yeah.
Anyway, thank you.
True. And you can start off with one patient, and then if the other physicians see that, what you did was actually in the benefit of the patient and everything, they would start referring more patients to you. So you can just start off with one patient and then go ahead.
Yeah, we usually imitate or follow the Western culture, even the treatment ICU, whatever it is. So in the Western country, they have this ethics committee, so we can.
Yes, we can.
Yeah, okay. Because it's a good thing to have.
Yeah.
Thank you.
Thank you, ma'am. Actually, that is a good thing that can be done. Having a committee as well as having a trial.
Yeah.
And getting that when the patient comes for a admission, saying about the next prognosis, like next time you come, you might the discussion can be made with the patient and the family during the discharge time. Okay, that is good. Thank you.
Because that time, the patient and family have seen an
they'll
episode.
be more receptive. They'll be more receptive,
exactly.
because they are going home. They will be receptive. So that
not
documentation can be
home.
done. Yeah.
No, they have seen the patient. They have seen
that,
all the events.
trouble. Yeah.
And how bad he was, how he has they themselves will see. As I am telling you, generally we say many times they'll walk into the hospital. Will they be able to walk out? No, they may need a wheelchair to get out. Okay. So these are situations where they themselves will see. So they may be in a state to accept, think, and whether you also tell them, generally, even with all these discussions, what we tell them is, you need not come back with an answer straight away. Okay, start thinking, look at, see what are the things, and then give the patient the choice, what is that he or she wants. Okay, and then come back to us slowly. I'm not asking you to tell the answer or anything now straight away, and you may not even come up with some queries. You may not be able to do that now. So you take your time, go back, and when you feel more comfortable, come back with the queries or some things that you want to bring up. That is how we say. Okay, so those are things which you can tell them and utilize each opportunity.
Okay,
That's
ma'am.
all. So these are
Yeah.
all things. No, all of every one of will make. See, always we say all these as guidelines or something. Then you make what suits you the best. Tailor make things to your situation. Tailor make things to your organization. So these are all some guidelines or hints and things given. Everything what works for Rutula or what works for me may not work for you, and it need not work for you. Okay, you take everything, pick up what is helpful for you, you make decisions and guidelines to your institution and do what is best for you and the patient. So that is what. So these are all a template which you can work on. Is that all clear? Because
Okay.
this,
Oh,
I
sure,
knew
ma'am.
that this will bring
Sure.
up
Yeah.
many things. That is one of the reasons why I picked up this case also. Okay, I knew that we should have something complicated, and this is what all of you will see on a daily basis. This is one respiratory. You can have cardiac. CKD is so common. There are so many on dialysis 3 times a day, consuming their time, everything for many years. Their progress, how the disease progression, quality of life, everything, and those 4 trajectories, please have a look. And any doubts and queries you have, please come up with anything like that. So understanding those 4 will be very, very helpful for all of you, and we will be going through that in the rest of our sessions also, many times more to come. As there are no more messages in the chat box, I will hand it over to you, Sri Priya.
Thank you, ma'am. Thank you so much. Thank you, Dr. Rutula. It has always been nice having you on sessions, and we do hope that we'll have more sessions with you in future as well. Thank you everyone for joining in and making the session as well as the case discussion interactive, because this is what we want at the end of the day, for everyone to learn more. And with the promise that we'll be meeting again day after tomorrow with another important topic and yet another experienced faculty. This is Sri Priya, along with Dr. Rutula Sonawane and Dr. Radha Venkatesh, signing up from the Tipsy Hub. See you in the next session. Till then, everyone take care. Keep spreading happiness.
Thank you, Rutula. Thank you, one and all.